Okay, welcome everyone. It's 3 minutes past the hour. I think it's a good time to start. We have a good crowd here. This is part of the Genomind Grand Rounds webinar series. My name is Dan Dowd. I'm Vice President of Medical Affairs here at Genomind, so thanks for joining us. We are really excited to have Dr. Robert Post present to us today on the topic of bipolar, specifically an update on treatment of bipolar disorders and the excess of childhood onsets in the U.S. Dr. Post is a legend in the field here. I'll give a brief introduction, and he has a lot to say, so I'll give a brief introduction, and then I'll hand it off to him to take it away. So Dr. Post is founder and head of the Bipolar Collaborative Network and professor of psychiatry at George Washington University School of Medicine, who was formerly chief of the biological psychiatry branch for many of his 36 years at NIMH, where his research focused on better understanding and treating patients with refractory unipolar and bipolar illness. His group has won major awards from the Society of Biological Psychiatry, APA, ACNP, Anna Monica Foundation, NARSAD, NDMDA, and in 2010, NAMI. Dr. Post is on multiple editorial boards and has published more than 1,000 manuscripts. He's the author of a recent book entitled Treatment of Bipolar Illness, a case book for clinicians and patients, published by Norton in 2008, and editor of the Bipolar Network News, a quarterly newsletter available online at www.bipolarnews.org. He is currently in private practice doing consultations on patients with difficult to treat mood disorders. So we're really excited to have Dr. Post present for us. And so that's enough from me. Let me hand it off to Dr. Post. Please enter your questions in the Q&A box at the bottom of the screen. And the format today will be roughly a 45-minute presentation, followed by 15 minutes of Q&A. So Dr. Post, I hand it off to you. Thank you.
Yeah, thanks very much for the introduction and the opportunity to present. I just want to point out that bipolarnews.org is a free newsletter for patients and clinicians, and everything I'm going to say today is pretty much in there too. So if you miss something, you can get more feedback from this newsletter. Oops, let's see if I can push this. Yeah, so there's a few conflicts of interest, but I'll try to make them irrelevant to this talk. And this collaborative network that we started had 4 sites in the US in blue, and meaning blue for sad, because you'll see that we have more problems in the United States than they do in Europe. 3 sites in Europe, in the Netherlands and Germany. And we treated tons of patients, studied longitudinally, and here's the summary. It's easy to get, and this is kind of the whole talk in summary, that the top left there's more genetic and familial risk in the United States than in Europe. More grandparental illness, more parental illness. Siblings and spouse have more illness, and the offspring have more illness. And there's more environmental adversity, bottom left. And those things lead to an earlier age of onset of illness and more adverse course of illness and more treatment non-response. So that's what you all in the United States have to deal with. And another way of summarizing this is that the genetic vulnerability is greater, there's more stress, and recurrent stresses sensitized to further stresses, episodes sensitized to further episodes, and same for drug abuse. So we end up with more severe illness in the United States than in Europe. So what are we going to do about this problem? We're going to attempt to avoid treatment resistance, primary prophylaxis in those at high risk. We actually don't know exactly how to do that, but treating prodromal syndromes is really important. And here's the new point: treat continuously after the first mania. That's not always said explicitly, but I think I'll show you the data that support that. So preventing illness, recurrence, and progression, treating anxiety and substance abuse comorbidities complicates this illness hugely, and going after those is a unique aspect of treatment, and it often requires complex multimodal treatment. So one of the issues is whether we had a funny subgroup of patients with more problems than anywhere else. In our bipolar collaborative network, 2/3 of the illness started before age 19 in the US and only a third in Netherlands. But in the STEP BD from the NIH, they had the same kind of incidence of childhood onsets in totally different cities, and the same thing for other registries in other European countries. So this is not an artifact of who we started seeing. And here's the double whammy. If you have early onset bipolar illness, it has a more difficult course, tons of data there. And early onset has a longer delay to first treatment, some cases a decade or more, and treatment delay is independently associated with a worse outcome in adulthood. However, the bottom line is you can't do anything about early onset necessarily, but treatment delay is a remedial risk factor that you can actually do something about and change it. Okay, so here's the problem. These are hugely more difficult patients in the United States that you're dealing with. More anxiety, alcohol, substance abuse, rapid cycling. Everything is more complicated. And their offspring are sicker. They have more unipolar depression, bipolar, suicide attempts, substance abuse in the kids. So more illness. And if we have parents and grandparents having more illness, the familial burden is huge. And that familial burden breeds true to the kinds of illness that is in the offspring. So this one looks a little complicated, but it tells the whole story. If you look at the bottom left there, 26 years of age is the average age of onset of bipolar disorder in our patients if they have low family illness burden and no childhood adversity. So that's more typical of what people think about age of onset. But if you look at the top right, all the red stuff, those are people who have both a high illness burden and a lot of childhood abuse history. And there you can see that the average ages of onset tend to be under age 13. So that's where we get the more childhood onsets in the US. Those two vulnerability factors are key, and there's many other ones as well. And Axelson in Pittsburgh case registry, he followed patients up for 7 years. He found that an amazing 3/4 of the offspring of a parent of a bipolar will develop a major psychiatric diagnosis of some sort. But even more surprisingly, 50% of the controls did also. So there's a lot of psychiatric illness in kids in the United States. So US patients with bipolar disorder are sicker than the Europeans, and so are their offspring, and that's what you got to deal with. And then look at this. It's not just psychiatric illness, it's medical illness. Banks did a study in Americans, 55-year-old white males, and they were sicker medically than the English in every category: diabetes, hypertension, heart attack, stroke, lung cancer, everything. So they concluded that, and they had all confounders covaried. It looks like from our data that there's 3 or 4 generations of psychiatrically more ill folks in the US, but we don't have it all covaried for confounders. But nonetheless, how will we deal with it? We can ignore it, or we can actively address the problem. And my take is that we need to build on what works for an individual, because there's so little data out there about how to treat childhood illness. And if we could develop practical clinical trials, give us some evidence of what works, that would be great. But until that happens, I think we need individual clinical trials. So here's the thing. We need intervention at earlier stages of onset of bipolar illness evolution. There's vulnerability factors, pre-symptomatic stage, prodromes, lots of anxiety, ADHD, conduct disorder, oppositional defiant disorder. Those things should be treated. And certainly when there's an onset of first syndrome, it should be treated. But all too often, we start treating patients after they've had recurrence or progression of their illness, which is a little late in the game. So we need to move treatment earlier and avoid the accumulation of stress and episode-related vulnerability that happens on an epigenetic basis. So you have early life stressors, and they predispose to later stressors, precipitating episodes of depression. The more episodes you have, the faster they come. Cocaine also sensitizes. So on the bottom right, you have more vulnerability from heredity, which stays constant, but stressors, episodes, and cocaine all tend to increase. So stressors, mood episodes, and bouts of substance abuse accumulate, and each so increase behavioral activity upon their recurrence. And each is driven by epigenetic effects, yielding alteration in gene transcription, which further drive the spiral of downhill illness progression. So that's the bad news. The good news is you can do something about all of these environmentally induced sensitizations. Try to avoid stress sensitization with psychotherapy, social support. Clearly, for substance abuse, someone with early onset illness is hugely more vulnerable to substance abuse and have an increased risk of acquiring it. It needs to be treated. And the main focus today is on episode sensitization and prophylacting that illness right from the get-go. So the epigenetic marks are acetyl groups and methyl groups that get added to the DNA. They don't change the genetic vulnerability. They just change how quickly genes are turned on and off. So this needs to be a whole cohort of docs and nurses looking out for childhood onsets, not only for bipolar, but also anxiety, depression, externalizing disorders. Solkoff and Garner said that pediatricians need to be the guardians of child health. So pediatricians have to play a key role in this. They see more childhood psychiatric illness in the United States than psychiatrists do. Adult psychiatrists need to ask about the children of their patients. And I even think patients need to take a proactive view of this whole thing and help docs recognize this illness. One of the key things with childhood onset is if you look at the right, attention, hyperactivity, impulsivity, racing thoughts, decreased self-esteem, they do not discriminate who's going to become bipolar versus who has ADHD. But on the left there, the things that do discriminate that you got to look out for are brief and extended periods of mood elevation, decreased need for sleep, and greater amounts of irritability and poor frustration tolerance. A little later in age, 7 to 10, is more sadness, suicidal thinking, physical complaints. And if the kid is propositioning his teacher in the 3rd grade that it's not ADHD. Also, hallucinations and delusions are not ADHD. So looking out for bipolar, treating it first is key. There's a high comorbidity of ADHD and bipolar illness in these kids. And these kids aren't getting treated well. 2.2 in the US have bipolar spectrum disorder, but only 20% are in any kind of treatment. And Geller followed up kids that she diagnosed with bipolar illness, and more than a third of them didn't get any treatment that's recommended for the illness during 8 years of follow-up. And the ones who did get lithium actually did better. So what do we need to do? Antidepressants are used most, but they're not very effective. And youngsters are at increased risk for switching into mania. So we need to think about possible preventive strategies, with primary prevention a possibility, at least recommending good diet, exercise, mindfulness, things that have no risk might be helpful. Secondary prevention, we don't have the data, but these are all low risk. And then the tertiary things that we do in adults are sometimes necessary for the kids as well. And we'll discuss those in a minute. Here's how parents can help. They can sign up for us to send them every Sunday night a secure email for rating the kids' anxiety, depression, ADHD, oppositional disorder, and mania. All they have to do is check into our bipolarnews.org newsletter and click on Child Network, and look what happens. Here's somebody who's rated every week for more than a year, and they were treated with all kinds of stuff on the top, and as you can see, it didn't work. So if somebody brings this kind of picture of illness to the physician, you can begin to start to deal with something that works better for mania, depression, ADHD, and anxiety. This will help guide therapeutics and help guide diagnosis. So very high-risk children, because of a parent or even grandparental illness is another risk factor. Good diet, exercise, education, coping strategies, mindfulness, mood charting, as I showed you. And think about family-focused therapy, as I'll show you. That's one of the best documented treatments. So here's the new message. Treat intensively after mania. And this is because, as I'll show you in a minute, Kessing showed that 2 years of expert specialty clinic treatment led to fewer relapses, not only over those next 2 years, but over the next 6 years, because the illness education therapy and all that led to better patient compliance and mood monitoring. Here's the other key thing. If you have a first mania, your cognition declines, comes back to normal only if there are no further episodes. Lakshmi Latham in Vancouver showed this, and it's also been replicated by 2 other people. So preventing episodes will help protect cognition in the brain. The other thing is, if you start someone on a first year of lithium compared to quetiapine, that turns out that in that first randomized year, everything is better on lithium, particularly in the second part of the year, in the Burke et al. Study. So here's the Kessing study. Look at this. If you have good treatment from the mood disorder clinic, you have fewer relapses than standard care. And standard care in Denmark is actually quite good. But the key thing is, after 2 years, the patients learn how to deal with the illness better and continued to have fewer relapses. So what does this mean? It means early expert intervention and patient education improved the long-term course of bipolar illness. Randomized clinical trial. So in refractory bipolar disorder, hopefully you can treat them early enough so it doesn't become refractory. But if it is, you need to be aggressive and innovative, find out what really works for your patients. It doesn't matter what anybody says or the FDA says, it's only whether your patient responds or not. And so I'm pushing this life chart picture as a key thing to have the patients help you do this to figure out what's really working for them. This will make a big difference in their compliance and in their ability to help you visualize the long-term course of their illness. So here are some of the things that we need to do. Lithium, carbamazepine, valproate, lamotrigine are the mood stabilizers, and lithium is best for classic mood disorder, no anxiety, substance abuse, that kind of thing. And if you look down to the, on the left side, it says family history positive. If you have family history positive for bipolar illness or lithium response, that predicts good lithium response. Carbamazepine is predicted by a negative family history for bipolar illness. And surprisingly, lamotrigine is predicted by a positive family history of anxiety disorders and substance abuse. So we have a few soft predictors of who's going to respond to which ones of these drugs. Here's the problem. Baldessarini did this study, and now there's a new one this year that says antidepressants are the main thing prescribed for people with a bipolar diagnosis. And so 50% compared to only 8% on lithium. So major problem. Antidepressants are not very effective, and lithium is used nowhere near enough. People don't know that lithium actually prevents unipolar depression better than some of the antidepressants do. And the good things about lithium need to be told to your patients because they never hear about it. It increases hippocampal and cortical volume, reduces dementia diagnosis in old age, it slows progression of mild cognitive impairment, has the best data for anti-suicide effects. And if patients still are reluctant, tell them that it's going to increase the length of their telomeres. Sometimes that really gets them. And then they say, well, I don't want to take it. It's got too many side effects. But these are overestimated, and long-term changes in renal function don't start for many decades. And actually, end-stage renal damage is more common in people treated with anticonvulsants than lithium. And they say, oh, well, it hurts your thyroid, but that's easy to replace. And lower doses of lithium will avoid most of the other side effects. Now, here's an interesting one that's not commonly recognized. The dihydropyridine calcium channel blocker, nimodipine, has antidepressant, anti-manic effects, lithium-like effects, and can supplement lithium's effects. And there's a gene, CACNA1C gene, that's a risk gene for depression, bipolar, schizophrenia, and autism. It's measured in the Genomind assays. And the question is, if your patient has that risk gene, will they respond better to nimodipine? That's a study that we'd like to do. So here's the other things that are approved for bipolar depression. Quetiapine in low and high doses is effective. Lorazepam is now effective. Cariprazine is now also effective for adults. And the bottom line there is lorazepam is now FDA approved for kids 10 to 17. And this is important because it's the only thing that's FDA approved for this age range for bipolar depression. And kids didn't need high doses. and they had moderate effect size with only 2% dropping out for either drug or placebo. And here's an interesting thing that Raison has shown, that in both the adults and kids treated with orazidone for bipolar depression, if they had an elevated C-reactive protein, a measure of inflammation at baseline, they actually did better, had bigger effect sizes. And usually that's the other way around. People with inflammation tend to respond less good. And if you look over unipolar depression, that's a predictor of some poor response to SSRIs or psychotherapy. But if you have high levels of C-reactive protein, you can actually get a better response to SNRIs and bupropion, to orazidone, as I showed you, but also to IV ketamine, minocycline, N-acetylcysteine, omega-3 fatty acids, and L-methylfolate. So this is an interesting predictor that can be used more routinely in clinical use. And the methyl tetrahydrofolate reductase deficiency is also included in the Genomind assay. And this is another important thing because it helps with treatment choice, because if somebody's got that deficiency, they really need L-methylfolate rather than folate to better convert homocysteine to S-adenosylmethionine. So maybe we should begin to do more C-reactive protein analyses in our patients. The other thing that's not commonly spoken in public is that combinations are more effective than monotherapy. And that goes across with lithium and other things, even Depakote and lamotrigine, which have kinetic interactions, they do better. And the atypicals added to lithium or valproate do better. So complex combination therapy is common with other medical conditions, almost always may be needed for treatment of more comorbidities. The key thing is if monotherapy, dual therapy doesn't work, you got to go there. And look at this, avoidance of side effects. People say too many side effects with too complex regimens, but if you do each addition carefully, you can get actually more efficacy and fewer side effects. Okay, so here are a bunch of comorbidities that need to be treated, and almost all of them are off-label except the Depakote stuff. Depakote for migraine, anxiety, alcohol avoidance. But the top left, N-acetylcysteine, helps with all kinds of addictions and habits. I'll show you that in a minute. And then on the top right, Acetyl-L-carnitine is good for pain, insulin receptor sensitivity, neuropathy, blood pressure. And then there's a bunch of things that are anticonvulsants, gabapentin, topiramate, and zonisamide, that are not anti-manic agents themselves, but have some pretty good data, like for gabapentin and anxiety and social phobia, alcohol avoidance, topiramate, alcohol and cocaine, zonisamide, alcohol and bulimia, and modafinil for some of these things as well. So thinking about off-label use is key for dealing with some of the comorbidities. So here's this N-acetylcysteine, and patients like this because they can buy it in a health food store. But it works in all kinds of drug addictions, gambling addiction, habits, pulling your hair out, trichotillomania, OCD, stereotypia, and autism. And it has positive data in depression and even negative symptoms, schizophrenia. So how the hell can one drug work in all these conditions? It's hard to conceptualize, but one way of thinking about it is that N-acetylcysteine increases the growth of glioglutamate transporters, decreases synaptic glutamate, and release in the accumbens. So the accumbens is where you have the automatic habit system. And if you decrease the excitability there, you restore cortical control, and that may help with a number of habits and addictions. So here's just a schematic of that. Number one on the bottom left, a lot of things decrease the release of glutamate, which drives anxiety and depression. Top right, 2, N-acetylcysteine grows glutamate transporters, increases clearance. And then you can block NMDA receptors potently with ketamine, which works quickly, but weaker with memantine, that works more slowly. And then there's acetyl-L-carnitine. There's low levels in the blood of unipolar depressed patients, a study in PNAS. And it's especially low in those with more severe early onset depression, treatment refractory, and get this, a history of childhood adversity. Because a history of childhood adversity tends to be a predictor of poor response to most things. So if you give acetyl-L-carnitine, that helps to treat the depression in multiple small studies. And this one acts by an epigenetic mechanism, turning on the DNA promoter for a metabotropic glutamate receptor, which inhibits glutamate release. And this drug works rapidly in animal models of depression too. So clinically and in animal models. So think about this one. And here's some of the best data on things that work for early on high-risk kids. The bottom there in yellow, people with family-focused therapy have greater benefits compared to treatment as usual for depression, stabilization, recurrence risk, psychosocial functioning, quality of life. And then I've added this thing at the bottom. Dave Michalowicz, who's done all these studies, is too reserved to say it, but I think family-focused therapy should be offered to all symptomatic high-risk children. It has pleomorphic positive psychotherapeutic effects. So we've got a new set of principles. Start prophylactic treatment after the first mania. If you do this expertly, you get fewer recurrences, not only after the first 2 years of randomized treatment, but over the next 6 years as well. Here's a key one. The cognitive deficits from mania improve only if there's no further episodes in that first year. You want to get after this illness well early, prevent episodes. The year of lithium is actually superior to that of quetiapine, Mike Burke's data, and try to help with the treatment of comorbidities and residual symptoms to remission, because if patients remain symptomatic, they're more likely to relapse, and even low-level symptoms tend to decrease functioning. So we have a key issue here of teaching patients and family members about the illness. Mood charting can help, recognizing early symptoms, starting pharmacotherapy and psychotherapy, particularly if the kid is abused, and establish an early warning system and a fire drill for what one can do if somebody goes off the rails with a full-blown mania, and maintain long-term full-dose prophylaxis. And if one does that, hopefully you can moderate the early course of illness and prevent the development of treatment resistance. So getting after this illness well early is the name of the game. So bipolar depression, relatively treatment resistant. You want to treat it to remission. More meds might get you there better, even with fewer side effects. The antidepressants are not very effective for bipolar disorder. And in kids, they increase the rate of switching. And lithium. Don't forget the use of lithium. And this is something you got to inform patients about. Tell them about the assets of lithium. They hear nothing about those except its side effects. Tell them about increasing their hippocampal volume, preventing dementia, decreasing suicide. And if nothing else works, tell them about their telomeres. Lithium directly turns on the enzyme telomerase, which increases the length of the telomeres. So treatment resistance, cognitive dysfunction, medical comorbidities, everything goes down the tubes with more episodes. So the new mantra is prevent episodes, protect the brain and the body. And we end up with the last slide here, and be open for your questions. So childhood onset bipolar disorder in the US is common. 2/3 of the illness starts before age 19. A quarter starts before age 13 and is poorly recognized, treated, and studied. So if you can get after earlier recognition and comprehensive prophylactic treatment, you can convert this more pernicious form of the illness into a more benign one. So with that, I think we'll close the formal part of the discussion, and we have plenty of time for questions. And I appreciate you all tuning in and spending some time over your lunchtime on this symposium, and hope you've got some new ideas about how to more aggressively recognize and treat this illness. So thanks very much for joining us.
Thanks, Dr. Post. That was great. We as expected, we have quite a few questions in the Q&A section. Please add more questions in there, and we'll try to, we have about 20 minutes. We'll try to get through as many as we can. One of the initial questions, and I had a similar question, you talked about the differences in the US versus Europe. What do you think is driving those differences? And are these differences a measurement issue, or is it a fundamental difference between the populations?
Yeah, I think it's a fundamental difference among the populations because, as I showed you in that one slide, there's a whole bunch of different studies of different populations in the US. And one of the studies was a different set of 10 different European countries, and they all kind of show the same thing. So I think it has to do with more familial illness in the United States. And that's not just bipolar, but there's more depression, substance abuse, all these other risk factors. And there's another genetic thing that we didn't mention, is that there's more assortative mating in the US. 3 times more of us marry a mate who has another affective disorder than in Europe. So you're doubling up on the genetic risk. And almost every kind of psychosocial adversity is almost double in the US. Physical abuse, sexual abuse, verbal abuse. And verbal abuse is quite a potent factor here. We looked at verbal abuse in our patients who did not have physical or sexual abuse, just verbal alone. And that also was associated with early onset illness and a worse course. So we have those risk factors, and we have other things like increases in obesity, poor diet, many other risk factors, and lesser access to good health care too. So lots of differences, but I think the genetics and the psychosocial adversity are big ones. And the Bank study of white males medically more ill, they weren't sure what the cause was there, but I think stressors are a potential issue as well. And those stressors put epigenetic marks on all kinds of things that lead to increased medical problems. So it's not clear exactly what's going on, but I think it's true that we all have a tougher to treat population in the US than in Europe.
Okay. You talked a bit about lithium. One of the questions we had is, how do you dose lithium for a pediatric population? And then in the context of unipolar depression, what kind of doses do you use as augmentation?
Yeah, both of those are good questions. The studies of lithium and mania by Bob Findling used regular therapeutic doses in these kids and got good anti-manic effects. My own take is that one needs to use doses of lithium that are well tolerated, both in children and adults. And if somebody gets tremor or other side effects, you should lower the dose and try to get the rest of the efficacy from somewhere else. So the augmentation strategies for lithium and unipolar illness tend to be better with over 750 milligrams, and using it all at night is more convenient and more effective. And the other thing about lithium is what you were asking, what the doses were.
Yeah, pediatric doses or augmentation doses.
Oh, yeah. And the other thing I was going to say is that the doses in Europe tend to be a little lower. And they didn't say what the doses were in a big study in Finland, but the unipolar depressed patients who are treated with lithium actually had fewer relapses than those treated with antidepressants or atypicals. So my take is, again, doses that are well tolerated is where you should go, because if you push patients to side effects, they ain't gonna take the drug and they ain't gonna like you.
So we're big fans of lithium here. We talk about it a lot during consults, but there's questions about a bunch of other specific drugs. I think you mentioned this in your presentation, but the dosing for NAC and acetyl-L-carnitine. NAC is usually in like the 2,000 to 3,000 range.
Yeah, it's usually 500 milligrams twice a day for a week, and then doubling that 1,000 twice a day. But in the studies of smoking cessation and in the kids with autism, it actually went higher. And it looks like it's well tolerated. The key thing with N-acetylcysteine is that you got to encourage patients to stay with it, because it takes 6 weeks to 8 weeks to really kick in. Like in the trichotillomania studies, they had a very high response rate to N-acetylcysteine, but it over 65% compared to 5% on placebo, but it took the 6 to 8 weeks to kick in, and it looks like it takes a while. And maybe that's because you have to grow these glutamate transporters. So higher doses are used for some of these studies, but mostly it's 1,000 BID. The other thing is with acetyl-L-carnitine, the doses aren't that well defined. I tend to use 500 milligrams 3 times a day, as that was in most of the studies of that in depressed patients. But that one remains to be studied further. The other thing with acetyl-L-carnitine is that you would wonder whether that might have good effects in patients who have early childhood adversity, because Nasca and colleagues found that it was lowest in the depressed patients who had childhood adversity, and maybe they need that drug replaced so that they can increase the inhibition on the glutamate system, but that remains to be directly studied.
That's a good segue to the next medication question. So, glutamate and NMDA, what's your opinion of memantine in bipolar and comorbid disorders?
Say mimicking?
Oh,
What do you mean mimicking?
memantine?
Oh, memantine. Yeah, well, those are interesting data. There's one study that showed that adding memantine to lamotrigine increased antidepressant effects, and that would make sense mechanistically. Lamotrigine's decreasing release, and whatever gets released is not acting at the receptor with memantine, so that could work. The other thing is there's some studies by Koukopoulos who added memantine to patients with very severe rapid cycling bipolar disorder, and he got a very substantial group of those patients not only better, but put some of them into remission. It was not a controlled study, just an add-on, but these patients were so sick, it makes you think that that's not a bad idea to think about trying for the treatment of refractory cyclic bipolar patients. So I'm kind of a fan of that for the most refractory patients.
I might as well ask this while we're talking about NMDA, dextromethorphan.
Yeah. Yeah, I think I'll pass on that. I don't know that much about that drug.
Okay. Question here about measurement or screeners. Is there a specific inventory you like to use for bipolar for children or teens?
It's a good question. There are some good screening instruments, parental rated ones. But I think you need to focus in on the specific ones that I pointed out that aren't common in ADHD. Those two are so often comorbid that you can't use ADHD in there at all. So you have to look at mood elevation, decreased need for sleep, increased sexuality, other things like that for the bipolar. But I think the key thing is being alert to the fact that, some things just aren't ADHD. Like if the kid's hallucinating and delusional, that's telling you it's more likely bipolar right from the get-go. So increased awareness, I think, is the key thing.
You had a slide in there talking about initial treatment for bipolar, and that, I forget the number, but most of the time it's wrong. Was that because it was being misdiagnosed, or it was correctly diagnosed as bipolar and they were just given antidepressants as a first-line treatment? Yeah,
that's the amazing thing. That Baldessarini study had 7,000 patients in there, and they all had a diagnosis of bipolar disorder. So the physicians wrote that, and they still went to antidepressants. And there's a more recent study now by Andy Nuremberg and colleagues just this past year, which essentially has the same thing, that the antidepressants are used more than almost anything else, and lithium is used fairly rarely. So it really looks like we get this thing not optimal for a whole lot of people. And we also have data in our network that the people who had more clinical trials of antidepressants before they came into our network at age 40 actually responded more poorly to our naturalistic treatment. So not only don't they work that well, they may actually screw up the course of the illness in some people. So if somebody's on an antidepressant and they have a really good response, leave well enough alone. Lori Ouchler has some data that if they're doing well for 2 months, it's reasonable to leave them on. But there's so few patients in that category. Maybe 10 to 15% of patients do well on antidepressant add-on. So it's a very small subgroup. So it looks like not only are we using more atypicals over time, but more antidepressants, which doesn't look great, and less lithium. So I think we need some revisions in our education of patients and trying to get them better treated right from the get-go.
Yeah. So it's the double whammy with bipolar. We're misdiagnosing a lot, and even when we're diagnosing correctly, we're not giving the right medications.
Yeah, and that goes with kids too, because Bermaher and Halfman in the Pittsburgh registry looked at all their kids, and they looked at the ones who were on lithium long-term versus the ones who were on anticonvulsants and atypicals. And the ones who were on lithium did much better, had less depression, fewer suicide attempts, all kinds of things. So that was also the case with Barbara Geller's 8-year follow-up study. The kids on lithium had more time in remission. So we really need to think not only more lithium in adults, but even more lithium in kids.
Yeah. The critics of pediatric bipolar, what do you say to them? The ones who say, there's no such thing as pediatric bipolar. It doesn't begin till later in life. How do you address those critics?
Yeah, there's all kinds of ways to do it. Ridicule doesn't work, but a little bit of ridicule might be useful, because 30 years ago they said kids couldn't be depressed, and now everybody knows that they can be. And so my take is why can't kids be manic? Especially when they present that way, and they are. So I think a lot of this is actually related to the differential incidence. Most of the people who say there's no such thing as childhood bipolar disorder are in countries where they rarely see it. Canada and all the European countries. And in the US, we have a whole bunch of experts who see it all the time. And one of the issues is the earliest presentation of these kids is often bipolar, not otherwise specified. That is, the kids don't have full-blown mania for a week or 4 days or something like that. They have rapid up and down. They're just manic for a few hours and then back down and crying. And if you don't count bipolar NOS in there, you're not gonna see it. And Bermaher's group had bipolar NOS being more difficult to stabilize. Took more than 2 years to stabilize those kids. So those kids are sick and need treatment. So my response to the critics is, both how are you going to treat them, and if they're so sick, just waiting for them to get sicker doesn't seem like a good idea.
Well, we're coming to the bottom of the hour here. I think we probably have time for one more question. My marketing department would kill me if I didn't ask you at least one question about pharmacogenetics. So where do you see pharmacogenetics? What's its place of therapy, in psychiatry now and moving forward 5 or 10 years?
Yeah, I like the Genomind profile because there's lots of actionable things in there. The serotonin transporter, which can give you evidence of poor response to SSRIs and tell you to go somewhere else. The the methyl tetrahydrofolate reductase telling you to go to L-methylfolate, the CACNA1C calcium influx gene, that's a vulnerability factor for all these illnesses. We don't actually know exactly how that predicts treatment outcome, but when I see that, I tend to think nimodipine, which blocks that calcium entry gene directly earlier in the algorithm. So I like all of these actionable genes, and hopefully we'll get more linked to differential treatment response. And I think that's going to be more powerful than the kinetic ones.
All right. Well, I think we're probably at the end of our time here. Dr. Post, I appreciate this. This was fantastic. I'm sure our audience thoroughly enjoyed it. For those of you listening, we will send out a follow-up email for all of you that are registered for this, including a recording of this. So thank you for attending. Dr. Post, thanks again, and everyone have a great day.